Daigaho and hello. Yes, this forum this morning is being recorded. Welcome in-person and virtual attendees. My name is Jeannie Wan, and I am the past board chair of the Chinese American Coalition for Compassionate Care. Today, I'm your co-moderator for When East Meets West, a Bridge to End-of-Life Care. I'm also the CME and CE coordinator for this extraordinary cultural exchange of best practices of end of life. Shortly after these slides, Dr. Gary Lee will be up next. But don't worry, I'll be back. And I'd like to now invite Dr. Lee to take over.
Thank you, Jeannie. Good morning, everybody. Thank you for all of you who've come in person and made it here on time. And welcome to everybody who's online. I'm Dr. Gary Lee. I am one of the co-chairs of CACCC and a almost retired hospice and palliative care physician. So first, I want to thank the sponsors of this program. You can see them here. We especially want to thank our platinum sponsor, the KNW Family Foundation, silver sponsors, the China Wind Foundation, AARP, and AARP California, our bronze sponsors, the SCAN Medicare Advantage Coalition for Compassionate Care of California, and copper sponsor, Santa Clara Family Health Plan. Also, we want to acknowledge our collaborating partners, El Camino Health and the Chinese Health Initiative, Stanford Health Palliative Care, United Pacific Financial Services, the Alzheimer's Association of Northern California and Northern Nevada, City of Hope, Bliss and Wisdom Foundation of Northern California, and the 50 Plus Foundation. I now want to introduce Dr. Jane Lombard, who will say a few words of welcome. Dr. Lombard is the medical director of the Women's Heart Center of El Camino Health and the chair of the Medical Education Committee here at El Camino, and she also serves on the Ethics Committee.
Thank you. I think it's the last two credentials that I'm invited here. I'm not going to talk about women's health, but welcome everybody, and thank you for attending this. I just want to share a personal story why I think this is so important. My parents are from China, and my father passed away 12 years ago, and he was 90 when he passed away, but he died of dementia. And before he got demented, I said, Dad, what do you want us to do? He had no advance directives, nothing. Says, bad luck to talk about death. I don't want to deal with it. Dad, but I'm here. I have to take care of you. Give me some direction. And he never did it. But before he got completely demented and sort of, not logical, I asked him the question. I said, do you want to go to the hospital? And do you want us to do CPR? I'm a cardiologist, so I see this all the time. And he says, no. I said, do you want to be on machines? No. And the last thing was, do you want to be on a feeding tube? And he says, no. And I recorded it because I didn't want anybody else, family members, whatever, to contest this decision that we had. And my mother was there. And he actually died of starvation. It took a long time. But I think this is so important because, I'm on the ethics committee, and a lot of our consults come from, end-of-life discussions and agency. Who's there to make the decision when the patient is unable? So thank you for coming, and I think we'll learn a lot in this exchange from a diverse panel from all backgrounds. So welcome.
Thank you, Dr. Lombard. So we're ready to start our program. This is really exciting, I think. As Jeannie mentioned to me yesterday in a message, this is probably the first time we've had a cultural exchange like this, an opportunity to exchange best practices of care at the end of life between the United States and China. So I'm happy to introduce our first guest speaker, Dr. Guijun Lu. Dr. Lu is a renowned pain management, hospice, and palliative care physician with Beijing Tsinghua Chang-Gung Hospital. Please pardon my pronunciation. I'm not a native Chinese speaker. And Xiamen Chang-Gung Hospital. His professional background includes various aspects of pain management and cancer care. For the last 25 years, his scholarship, publications, and public speaking have focused on improving end-of-life care in China. He's the Deputy Editor-in-Chief of Chinese Life and Death Studies, and we're happy to be able to host him and look forward to learning from each other about how we can better care for our Chinese patients and families as they face serious illness. So Dr. Lu.
各位同仁，大家好。首先非常荣幸能来到这儿，也感谢美华慈心对我这次美国之行的支持，谢谢各位。
Good morning, everyone. Very glad to be here today, and I would like to thank CACCC for making the arrangement to.
在中国医学教育中，其实没有死亡教育。我们对医护人员的褒奖仅限于妙手回春，让他尽快康复起来。
In China, when we teach medicine, we don't really teach about death. We teach about treatment and try to cure people.
但是死亡每天在发生，中国大陆平均每年死亡人数是1000万左右。
But death happens every day. In fact, in China, about 100 million people die every day.
我们统计数据在大陆1000万死亡人数中，大概只有不到10%最后阶段得到了医疗照护。
Sorry, 10 million people die every day, and out of these 10 million people, maybe only about 不到10%，
对对
，less than 10% of them actually got hospice care.
然后我们发现一个好的死亡，它一定是遇到一个好的医疗团队，所以说医护人员他对死亡的态度完全取决于患者的生活质量，决定了生活质量。
And for those people who have a good death, it's entirely depend on if they have the good fortune to meet a good team to take care of them at the end of the life. So meeting a good hospice care team really determines the quality of the patient's life.
所以说我们现在面临的第一个问题是如何正视死亡。当患者真正要死的时候，他知道死亡是怎样的过程，而且医生也有这样的知识储备可以帮到他。
And so the first thing we need to do is to help the patient look at death directly. And if we have a good understanding of what death looks like, then we know how to take care of this patient properly.
所以说今天我讲的就是基于中国人对于生命的信仰做的安宁照护，所以说叫中国特色的安宁疗护。
Today, the palliative care that I want to talk about is based on Chinese culture and Chinese beliefs, and that's why I call it palliative care with Chinese characteristics.
其实在中国文化中，对于死亡很早就有一个比较通俗的理解，叫善终。
In China, even since a long time ago, we understand death as good end or good death.
善终呢，它是这样描述的：当一个人走到生命尽头的时候，可以预先知道自己的死亡时间，身体没有病痛，心中了无挂碍。
And what good death or a good end means for Chinese is that they saw it coming and they don't have any worries or concerns when the time they pass.
和自己的身体、心理、社会以及大自然最后得到了和谐，告别这个世界。
They can achieve harmony or make peace with the environment, with the society, and with themselves when they are leaving the world.
如果他心中有信仰的话，他离世那一刻，鼓乐齐鸣，而他跨河西游，奔赴他的信仰。
When they have faith in their mind, then it's a moment when they can actually embrace that faith to meet that final destination in their mind.
其中善终呢又分为3个层次：小善终、中善终和大善终。
There are 3 tiers for a good end or good death: the small one, a medium one, and a large one.
小善终呢是基于生物层面的，预先知道自己的死亡时间，没有遭遇意外和横祸，身体舒适，没有病痛，寿终正寝。
The small good death or small good end is more on a biological level or physiological level. That means that they see this death coming. There's no accidents or a huge trauma to them, and that they pass away peacefully.
中善终呢是身体舒适，心里没有了无挂碍，还可以 安详的处理世间所有事儿，和家庭社会和解，告别这个世界。
And a medium good death would be that they don't have any worries or concern bothering them at the time that they pass. They have had the time to handle all their personal relationships properly before they pass away.
最圆满的善终是大善人，就是预先知道死亡时间，没有遭遇意外横祸，身体舒适，心理平安，而且最终奔赴上了自己的信仰。
And the large good death, or the highest level of a good death, is that it's a physiologically, you know that you're going to die, and you have handled all your relationships properly. You make peace with everything before you leave.
那我们与之相匹配的医疗模式是这样的，分为住院的安宁疗护和安宁共照，以及医联体安宁，就是社区安宁和居家安宁，分3个部分。
And so correspondingly, we have different levels of palliative care. The first level would be specialty palliative care, and then there's the multidisciplinary palliative care, and then also a medical network and home palliative care.
在住院阶段的安宁，就是第一部分，它又分为特需安宁、医保安宁和日间安宁。
For the hospice hospice palliative care, there's specialty palliative care, daytime palliative care, and insurance-covered medical daily palliative care.
特需安宁就是基于特殊需求的人高端的医疗，医保安宁基于国家医保制度的普通民众，日间安宁的就是病人在居家状态，如果突然出现身体状况，24小时内在医院进行住院治疗的医疗模式。
For the specialty palliative care, it's a more high-end type of care. So it's for people that have the special needs. And for insurance-covered medical palliative care, it's something that's covered by insurance. And for the daytime palliative care, it means that the patient is in the hospital, and if there's any need, it can be covered and can be cared for.
安宁共照就是基于综合性医院其他各科室，如果出现临终患者的话，它有个自动数据抓取系统，直接会抓取到安宁各管师。这个安宁各管师呢，会主动的去走到床旁，询问这个患者和家庭是否需要安宁照护。
And the second tier that it's the disciplinary palliative care, that there's data that can be automatically captured, and if one of the physicians or one of the care providers sense that there's some need from the patient, then the case manager can approach the patient and try to help the patient with that need.
医联体安宁和居家安宁就是针对患者症状比较轻的，可以住进低级别的医院，有高级别医院大夫每天巡诊，提供医疗照顾的模式，具体由低级别医院医护人员配合。
And for the last tier, it's a medical network palliative care and home palliative care. That means that the patient is not in huge needs for a lot of care, and this kind of care usually is provided by a lower tier or local regional providers from the regional hospitals.
那居家安宁的就身体症状层面，需要管理症状很少，相对舒适的可以在家庭居家安宁，然后由我们的志愿者隔日上门一次提供1小时的照料服务。
For the home palliative care, it means the patient doesn't have a lot of symptoms to manage. It's not a very tricky case. We will have volunteers come visit every other day and to stay with them for about an hour.
当然了，这种模式并不是国内全部通行的，而是在北京地区的一个代表。
And this model that we are talking about, it's not universal across China. It's just representative in Beijing.
那我们在做生命末期照顾的时候，发现和常规医疗模式是有本质区别的。
When we do end-of-life palliative care, I think it's fundamentally different from how we usually treat people.
在常态医疗中，我们更多的需要患者和家属的依从性，要听从医生的建议，医生带着你奔赴健康。
And usually when we treat people, treat the patients, we need high compliance. We want the patients to work with us so that we can work the providers and the patients can work together to become healthy.
而在患者临终阶段，更多的是患者和家属都知道自己罹患这个病情呢，与事无补，再也无法恢复健康。他们自己想要的那种好的死亡方式掌握在自己手里，所以说依从性是反过来的，需要医护人员多倾听患者和家庭的需要。
But at end of life care, the table is turned because at the time the patient and the family, they're well aware that there's not much time left. So it's the providers that should be listening. They are the one that should be complying with the patient's wishes.
服务于患者生命尽头，我们发现其实医学并不等于纯科技，医学一定等于科技加人文。
And we realize at the end of life, medicine is not just science, it's science and humanity.
在疾病早期，我们确实通过医疗科技可以为生命平添时日。这一点，我们发现科技让我们从未来、梦想、智慧全维度去理解了医生的使命、担当和责任。
At the early stage of illness, it's possible to use medicine, to use science to earn more time in life.
那在疾病末期，我们发现医疗科技变得苍白无力的时候，用人文可以维持不多的生命赋予意义。这一点，我们发现人文让我们从历史、空间、情感全维度去理解了使命、精神和担当。
But at the end of life, science can't really do very much at this time. So this is the time where humanity comes in. We want to use humanity to attach more meanings to life instead.
那今天呢，我想从3个部分跟大家分享在中国对于死亡的一些态度。第一个是生死之纠结。
So I would like to talk about how we look at death in China from 3 aspects. The first one is the knot of death and life.
第二个是人文之源，人文照护的原本应该是什么样的？给予什么样的照顾才叫人文照护？
The second aspect I would like to talk about is the origin of humanity. What makes humanity?
第3点是善终之本，一个好的死亡，它原本的状态应该是什么样？
And the third aspect I would like to talk about is the essence of a good end or good death.
第一部分面临生死的内心纠结。
So let's start with the knot of life and death.
在中国有一句俗语，癌大莫过于心死而人死以次日，就是一个人心中的希望一旦破灭以后，他的身体彻底死掉了，身体什么时候衰竭已经不重要了。
In China, there's a saying that it translates to something like the greatest sorrow in life is when life becomes hopeless, when there's nothing to look forward to. And at this point, even when it doesn't matter when the organs are going to fail, when the body is actually going to die, because there's nothing to look forward to anymore.
我们在临床看到的癌大莫过于心死的案例，更多的是患者一住院以后寻求安乐死，尽快结束自己的生命。
And in clinical practice, we see a lot of patients, when they experience this greatest sorrow, meaning that they don't have anything to look forward to anymore, usually the approach they would like to resort to would be assisted suicide.
当我们详细了解病史，你会发现这个患者一定是非常痛苦，是痛苦的被痛苦折磨而寻求死亡。
And if you really get to know these patients, you will see that the reason they will want assisted suicide is because they're in great suffering, they're in so much pain, they just don't want to live anymore.
在中国背景文化下，我们理解，不惧怕死亡有2种基本情况。第一个是生不如死啊，活着没有死了那么幸福，还没有死了好。第二个就是基于特殊的信仰而寻求死亡。
In Chinese culture, there will be 2 reasons why some people would want to die voluntarily. One is that they don't have any hope in life. There's just nothing to look forward to. And the other thing would be for a certain belief that they have.
那信仰层面的问题，我们很少能在短时间内进行干预。而第一个那种生不如死啊，就是活着很痛苦。只要你缓解痛苦之后，你会发现患者他会告诉你，那谁不想多看世界2眼？
If it's for some certain beliefs, there's nothing much we can do about it because it's hard to change someone's belief in a short period of time. But if it's for the first reason, it's because the patient is going through so much suffering, being in such a miserable state, then that's something that we can address. If we can help them to feel less miserable, then oftentimes you will hear patients say that if we can, of course, I would want to see more of the world, have more time here.
所以您会发现，缓解症状对一个临终患者有多重要。一旦症状缓解之后，他们往往会放弃安乐死的想法。
That's how we can see why it's so important to help manage the symptoms. Once the symptoms can be managed, you will see that patients actually want to live.
但是做了安宁疗护以后，我们发现，那种癌大莫过于心死，并不是人生极致的痛苦。
But once I started doing palliative care, I realized for those pain, those great sufferings that would make people want to die, it's hard to manage.
我们发现人生极大的痛苦是在抗拒死亡中接受死亡，有很多愿望没有实现，而身体已经垮掉了。
I think the biggest pain would be when you still have a lot of wishes. There's still a lot that you want to do, but you know very well that you cannot accomplish those anymore.
我经常举这样例子，比如我今年50多岁，我突然某一天被诊断重大疾病，而我起码感觉还有20年的事没干，我非常不甘心，但是身体一天天垮掉，这就是挨打莫过于心不死。
And I often give an example. Like, for example, I'm in my 50s now, and if I get a real poor diagnosis that I become critically ill, I'm going to die soon, then I know I've lost 20 years of my life at least. I could have lived to 70, but I don't have those 20 years. That means there's 20 years of time of things that I want to do, but I cannot complete. So that would be the greatest pain emotionally for anyone to go through, knowing that there's a lot to do, but also knowing that you cannot do them anymore.
那对于这种患者的照护，我们如果把他大的愿望分解成小的愿望，让每一个小的愿望变得可及，即便走到生命尽头，依然有阳光照进他的生命。
When we care for patients of this kind, meaning that they still have a lot that they want to do, we try to break down their wishes so that we can still help them achieve something, and that gives them some sort of hope or light in their life.
所以您会发现在生命尽头有很多矛盾会集中呈现。
At this time, you will start to see a lot of conflicts or paradoxes in life.
我们发现人的一生呢，一直处在矛盾中。中国有句俗语叫“30而立，40不惑，50知天命”。但是我们做了安宁疗护，发现人一生都在成长，尤其是临终之前，成长最为迅速，矛盾也更为突出。
And throughout our life, there's always a lot of paradoxes or a lot of things that's conflicting that you have to make peace with. And in a Chinese saying that we would say when you reach 30, you should be self-sufficient. And when you reach 40, this should be a time that you don't feel confused or lost anymore. And when you reach 50, you should be able to make peace with everything. But in reality, that's hardly ever the case. You are always growing, always learning, and you reach the biggest or highest moment of paradox or at the time that you know you're going to die.
大家看这个字，这是中国的“我”字的书写方法。
This is how I is written in China.
它是一个会意字，它本身就形容包含了我本人就是人本人就是个矛盾体。大家看呢，旁边是两个兵器，在中国传统文化中，他认为我是一对矛盾体啊，短兵相接，背对背，中间一横是一生都在寻找这个在矛盾中的自洽点。
And if you look at how the I is written, means myself is written, it looks a lot like two pieces of weapons. These are spears or blades placed to each other. And you try to make peace between these two pieces.
所以说我们了解自己始终就是在矛盾中成长的，包括生命尽头。我们安宁疗护除了身体症状关照以外，就要处理和干预患者内心的矛盾和冲突。
And self-growth or personal development, a lot of it is to understand those conflicting thoughts or beliefs or those paradoxes among yourselves. And as providers, when we care for the patients, we want to understand what they are worried about or what are those internal paradoxes that they have going on.
希望在生命尽头，在缓解患者症状前提下，能引导他在矛盾中找到生命自洽，寻找到最终的那种和谐。
And in this process, we hope to address the symptoms, to manage the symptoms, but also to help them make peace with all these paradoxes that they have in their mind.
所以我们说，死亡可以简化人的生命程序。
So in a way, death helps streamline a lot of paradoxes that you have in life.
给大家举个例子，比如上一周我在查房的时候，我们有一个社交达人。他到生命尽头给我看他的手机，他说：“你看，我现在仅剩下10个联系方式。”
Last week when I was rounding and I met a patient who's a bit of a social butterfly really, but then when he showed me my phone, or he or she, the patient showed me my phone, there's only about 10 contacts left on that phone.
这就是死亡可以简化人生命成就的表现。他把原来不重要的人全都删除了，剩下的全是他爱他的和他爱的人。
That's how death help you streamline things in life. You get rid of all those people that you don't care anymore, and all the contacts that you have on your phone are the ones that you truly care.
这就是矛盾中获得成长，获得人生的一种相对简单的自洽。
That's how you try to grow, try to make peace with life.
接下来第二方向，我想跟大家聊一聊人文之源。在中国背景文化下，人文照顾它根本的初衷和目标是什么？
Next, I would like to talk about the origin of humanity in a Chinese context, what it looks like.
那说到人文呢，一定要说到文化。所以今天呢，我还想从3个人文和化分别说一说，在中国人文照护是什么。
So I would like to address human and culture.
大家看人文化这3个字它有象形文字，有会意文字。
So this is how you write human and culture in Chinese, and for some of it you can kind of decipher what it means from just looking at the character. Some of it you can't quite tell what it is by just looking at it. You have to try to understand it.
这是第一个人字。
This is human or people in Chinese.
人字的书写就是这样的。在中国文化中，我们认为人应该是谦虚的，所以说您看他比较谦虚的，在鞠躬一样。我们要敬天、敬地、敬畏生命，也敬畏自己。
This is how people or human, that word is written in Chinese, and you can see it looks a lot like a person that's bowing. That's because in Chinese culture, it's important to be humble, to be in awe of nature, of the society, of life.
在安宁疗护工作中，我更愿意把人理解为敬畏大自然敬畏生命的一个个体，一个载体。
And in palliative care, that's what we look for to be in awe of nature, of people, of life.
那第二个，我想谈一谈文。文呢，大家看这个文字呢，就是一个人张开双臂站在你面前，这就是文。
This word in Chinese, it could mean culture or literacy, and it looks like a person that's standing there with the arms open.
他张开双臂站在你面前，是在向你展示心中的信仰比如说旁边这2个这个人，他们脸上的豹纹、身上的宇宙纹，都是展示心中的信仰。那在原始社会，所有的先祖们，他们经常把民族的徽号和氏族的象征刻在自己脸上，纹在自己身上。
And when a person stands in front of you with the arms open, that's because they're open to share their beliefs or what's on their mind with you. And you see in some of the ancient tribes, people will have the symbols of their tribe, of the culture tattooed on their face, on their body, so that it's all out there for you to see, to be shared with you.
我再举一个通俗点的例子，现在各个国家的国旗，它国旗上的图案基本上就是这个国家的信仰，这就是文的意思。
And for another example would be if you look at the national flags, usually whatever appears on the flag is what the country wants to share with you, want to let you know what my country is about.
那结合到我们医疗工作中的案例，我想有几个图片，它充分反映了这种纹饰，它向你展示的就是心中的信仰。
And here I want to show you a couple of pictures of how people use these very opened kind of images on their body or tattoos on their body to really show that what they believe in.
大家看中间这个图片，这是一个36岁的父亲，他的6岁的姑娘告别世界之后，他把姑娘的照片纹在了自己前臂上。
The picture in the middle is a tattoo of a dad, and the dad is about a 36-year-old dad. And that picture of the little girl is the 4-year-old that he had when she passed away. He got that tattooed on his arm.
姑娘去世之后，他去西藏旅行，和他爱人拍合影照的时候，把上臂的袖子捋起来，他要拍3个人的合影照。
And after the daughter passed away, the couple went to Tibet. And when they were taking this picture, he rolled up the sleeves because he wanted to take a family picture of 3.
其实旁边写了几个小字：行越远，心越念。
行越远
走得越远，心情越惦记。
And there's a little words we probably can't read on the arm. It's part of the tattoo. That means that the farther you travel, the more you miss this person.
我曾经和他有一次对话，我说博尔斯，南美洲的博尔斯曾经说过，如果有天堂，天堂一定是图书馆的模样。您认为这句话对吗？
I once had a conversation with this father. I shared a saying with him, saying that if there's heaven, then heaven must look a lot like a library. Do you agree with that?
他说我反对。我认为我姑娘在哪儿，哪儿是天堂。
He said, I disagree. I think heaven is where my daughter is now.
所以说我问他，我说姑娘是不是已经活成了你的信仰？他说是的，就是那样。
And I asked him, do you think that your daughter has become part of your faith? And he said yes.
那个旁边那个女士啊，最那边图片，她的姑娘去世以后，她把姑娘的名字纹到自己桡动脉上。
And this lady in the picture also has her daughter's name tattooed on her arm when the daughter passed away.
我问她为什么会这样，她说此生为她而来，每一次心跳都是为了她。
And I asked her, why did you do so? She said, that's because my life is all for her, and every heartbeat that I make is about her.
我们看到文化是生命的信仰，到现在依然在展示它的作用。
So we can see sometimes for culture, it's part of your beliefs of life.
所以说，我们做安宁疗护一定要了解患者的生命信仰是什么，基于他的信仰照护才是真正的人文照护。
When we provide palliative care, it's important that we meet the patient's beliefs, whatever that they believe in life.
我们看在最后一个画字，生命文化的画字。
This last character 画 it's part of culture in the Chinese word.
它是一个会意字，用图形展示它的意思。一个头朝上的人，一个头朝下的人。头朝上的人是活着的人，头朝下的人逝去的人，就是生死之间叫化。
And when you look at how this word or this character is written, it looks like one person is standing upright and the other one is upside down. And so it's a living and a dead person.
所以生死间的文化就是生死间的信仰就是文化。
So what you believe about death is part of your belief in life or of your own culture.
我们敬畏自己的生死间的文化，那就是人文照护。
If we can respect people's belief in life, people's culture of life, then that's respect death.
这个图片是在西藏天葬台，大家知道西藏的藏民去世之后，他会把自己身体喂了鸟，叫天葬。
This is a burying altar in Tibet. In Tibet, there was this traditional practice when people passed away, they used the dead bodies to feed birds.
大家会看到这是一个充满神圣感的地方。
It's a very sacred place.
当时我问当地藏民，为什么你们要采取这种方式告别这个世界？
I asked the local people why they use this way to pass or to leave this world.
他们告诉我，一生得到了太多的大自然的馈赠，猪、牛、羊、马肉和各种动植物。
And I was told that's because throughout life we have received so many gifts from nature, all the lamb, pork, beef that we eat.
所以说，生命尽头，他会把自己的身体还给大自然，在中国文化中叫以身布施。
That's why at the end of life they want to return to the nature, to give the body back to nature.
而那种食腐动物秃鹫，它飞得最高，在8、9千米高空，离它的神最近。
And the vultures, the birds that will eat the body, they fly very high. That means they're closest to heaven.
他们天葬就希望自己第一把身体还给大自然，第二个让秃鹫带着它奔赴向他的信仰，他的神堂。
So the reason they have the dead bodies fed to birds is because first they want to return their bodies to the nature because that's where we came from, and then also so that the vultures can take them to God, to a place that's closest to God.
所以说中国呢是个多民族的国家，如果我们照顾的患者是个藏民的话，最后你一定要帮他实现他回归大自然的愿望，这就是善终。
So in China, there's many different ethnicity. If you happen to be treating a patient from Tibet, that it's important to respect their wishes to return their body to nature in the end.
大家看到这个一排小房子刻着咒语，它是有很多藏民到年迈之后，他会申请当地寺庙或者是当地政府在这盖一间小房子，住在这里。
You see a lot of these little houses. These are little houses here, and they all have some sort of words or spells on them. And that's because towards the end of the life, they use the local people, they will request to have a little house like this built.
我问他们住在这儿干嘛？他们说为已经往生者祈福，为自己祈祷。
And I asked them, why do you want to live in a little house like this? And people would say this is to pray for the ones that have, for the people that have passed away, and also to pray for myself.
我想这完全就是排队进天堂的感觉。
This looks a lot like you are standing in line to enter heaven.
这种想法可能在很多民族中不可思议，但是他们觉得那才是人生极致的幸福。
This might sound unbelievable to a lot of people, a lot of cultures, but for these people, that's the ultimate happiness.
所以说呢，从人文之源，我们看到了，当患者身体舒适以后，最好的人文照护就是基于他的信仰做的照护，实现他最终的愿望这才是真正的人文之源。
So when we talk about the origin of humanity, that means when we provide palliative care, the ultimate goal is to respect their beliefs, to meet their, to help them achieve their wishes.
那最后跟大家分享一下我们对善终它原本的要求是什么，善终之本是什么。
And lastly, I want to talk about what's the essence of a good death.
在中国做安宁疗护，我们特别推崇生死教育。如果死亡话题说都不能说，谈都不能谈，你怎么做呢？所以说生死教育显得尤为重要。
In China, when we want to talk about palliative care, it's very important that we educate people on death. If you don't even dare to talk about death, how can we even provide you the appropriate care?
中国有一句古话，对于生死教育应该是焉足于法于天下而不伤其身，道足于化于百姓而不伤其本。它的意思是，生死教育是引导而不是教化。
And in Chinese, there's a Chinese saying that means that when you do these life education, life and death education, the purpose is to guide them, is to provide guidance, not to lecture them.
那生死教育呢，就是作为安宁疗护从业者，不是在生命尽头把它教化成我希望的样子，而是希望他生命按照自己的正常的流程走。当遇到阻隔的时候，给予引导，让他实现自己一生的一个信仰和想法。
And so when we provide palliative care, when we do this life and death education, it's important that you don't try to lecture them so that they mold them into what you think things should be. You should respect their wishes to let things unfold naturally. And when they encounter any obstacles, you try to help them get over that obstacle.
所以我们的工作的目标是希望每一个人不管什么时候走到生命尽头，都可以全心全意的接纳死亡。心满意足的结束自己的旅程，就像一颗熟透的果子告别枝头一样。
So the goal of our care is that we want to help patients to fully embrace death when the time comes and to happily leave or go on when it's the moment. Just like how when a fruit is completely ripened, it will just fall naturally.
这就是我们希望的基于大自然和生命敬畏的善终。
That's the good death or good ends that we would hope for, that it respect wishes, that it's in all of nature and life.
以上是我分享的基于中国传统文化安宁疗护照护希望的目标和希望达成的共识。
That's all I have to share with you about palliative care based on Chinese culture and Chinese beliefs.
感谢各位的时间，谢谢您的聆听。
Thank you. Thank you all.
Thank you, Dr. Lu. Okay, our next speaker is Dr. Esther Lo. Dr. Lo is the physician lead for the outpatient palliative care program at Kaiser Permanente Santa Clara Medical Center. As the outpatient lead, she has created an oncology supportive care clinic embedded in the Department of Oncology and a home health specialty palliative care program. Esther attended Scripps College in Southern California, went to UC Davis for medical school, and did her internal medicine residency and chief residency at Santa Clara Valley Medical Center, where I had the honor of being one of her attending physicians and learning from her. She was one of our first residents to go on to a fellowship in palliative care, and she completed that at Harvard Medical School. So Esther, welcome.
Good morning, everyone. 早上好. I first want to thank Lu Yisheng, Dr. Lu, for such an amazing cultural education. I really enjoy that, and really helping us better understand our Chinese culture. I'm a first-generation Chinese American. I was born in Guangxi, China, and then immigrated to the United States when I was 10 to be with my grandparents. So here's my title for my presentation, is Blending East and West, a palliative care physician's perspective on living on serious illness in the Chinese community. So I want to start out with a story. She is a 89-year-old Mandarin-speaking woman, and she was diagnosed with advanced lung cancer. She has 3 adult children. Her elder and the youngest daughter spoke limited English. Her second son was a physician in China. She decided to appoint her 2 sons as her healthcare decision maker. So when she was diagnosed with cancer, she and the family decided to forgo cancer treatment. She was pretty well, actually didn't have a lot of symptoms at the time, and continued to attend church in Chinatown in San Francisco. Over a year later, she developed fatigue, and one day she coughed up blood. She and her family really did not talk in any depth about her medical wishes, and the family rushed her to the hospital to be evaluated. So in the hospital, they get a blood test, they got a chest x-ray that actually showed wildly metastatic cancer and possibly pneumonia, so she was given antibiotics. And there was a palliative care consultation that was put in the chart, asking for the palliative care team to talk about goals, to talk about hospice planning. So she was on high flow oxygen, so there's no way for her to be discharged home. This is probably the hospital's biggest nightmares, cannot be discharged home. So she couldn't be discharged home. There was also family tension that developed during the hospital stay. So some of the family members wanted her to be moved to the comfort care suite. And then other family members totally disagreed because they felt that if you moved her to the whichever floor this was at UCSF at the time, you're going to hasten her death. Her swallowing during the hospital stay also became more and more difficult, and her family continued to try to bring her homemade food and try to feed her. And so I share this story because this was my grandmother. She died many, many years ago in the hospital at UCSF. And at her time in the hospital, all of her children, her adult children, and also grandchildren, I was one of the grandchildren, we stayed with her 24/7. This is before COVID, where we can really stay with our patients and families. I share this because I was a training resident at the time at the Valley, and I found it extremely, extremely difficult to talk to my grandmother, who I grew up with in China, about her illness. I have found it hard to talk to my aunt and my uncle and my parents. And so I wish at the time we had palliative care, that her doctors actually talked to us about palliative care so that we can actually have that a year earlier when she was diagnosed with her cancer. So the objectives for today is that I want to discuss some cultural considerations when discussing serious illness. We heard a lot about the Chinese culture from Dr. Lu already, and then also trying to integrate some practical approaches as well. So Chinese Asian is the largest Asian population here in the United States, about 24%. And that totals about 4.4 million people. And 25% of our Chinese Americans actually live in multi-generational households. This is compared to about 20% in the US population that live in multi-generational households. So the Pew research in 2019 indicated that 62% of Chinese living in the United States are foreign-born with variations of acculturation into the American culture and also their English-speaking fluency as well. So as the population is growing here in the United States, people are living longer and also with more serious illness. So the top 3 causes of death, first one being cancer, followed by heart disease, and then stroke. So this survey was done by the Coalition for Compassionate Care in 2019. And one of the survey questions asked, if you had an advanced illness, what would you prefer? All right. So, so you can see that more than half of Asian Americans prefer a natural death. And then there's a few, 13% actually prefer to pursue aggressive end-of-life care to be kept alive. And then what's also interesting is 1 in 4, about 26%, actually don't know what. Studies looking at a good death here in the United States, in this particular paper published in 2020, defined it as one's accomplishments of familial responsibilities. So for example, knowing that your children received good education, they got married, they have children, that's defined as an accomplishment. Natural death in old age, minimal suffering, free from pain, and then maintaining good family relationships. Again, some of these Dr. Lu already alluded to, kind of the small, medium, large of a good death. Studies also show that in the Chinese American population here in the United States, they actually receive more aggressive care at the end of life compared to their white counterparts. So Chinese Americans more likely to die, to receive invasive mechanical ventilation in the hospital at the end of life, and also more deaths in the ICU compared to their American counterparts. So what are some strategies then can we have to incorporate to help us take better care of our patients, Chinese American patients? So I'm going to share 7 tips today. Hopefully I won't run out of time. So the first tip is really, this is focusing on medical decision-making and the family structure, okay? So, and this is important because it has several implications when it comes to advanced care planning and goals of care discussion. So there are 2 components. And the first component is really the collective decision and not that of the family. So this, in order to really understand this, you really have to understand the Chinese family and the structure and the hierarchy. So when you have a patient, it's important to ask, is there an eldest son in the family? Is there someone, I see nods, yeah. So is there someone who's a doctor in the family, or a nurse or a pharmacist? Because as part of the hierarchy, there's a tendency to pick the eldest son or family members who are healthcare providers as the guide in terms of the healthcare decision maker. So the second component, so in my grandmother's situation, right? So my grandmother can actually very well still make her decisions even when she was admitted to the hospital, but she chose not to and actually gave that responsibility to her adult children. So my eldest, so to her eldest son, who's my uncle, and my uncle then relied on my father, who's the physician, for all the medical information. And they then in turn made decisions on her behalf while she was hospitalized. So the second point here is really optimizing for the benefit of the family and not of the patient. So I would say this is probably one of the most challenging for the medical team. Okay, so in America, the medical team will always try to talk to the patient first, right? We teach this to our residents. Please don't talk to the family first. Please always go to the patient, ask, what does the patient want? However, in the Chinese culture, the patient is actually more concerned about the family and the well-being of the family over his or her well-being. So in the decisions that rest, the decision rests is on what benefit the family the most. So several years ago, I had a Cantonese-speaking patient who had advanced lung cancer that actually invaded her brain and caused her to go blind. She was living with her son and her son's family. They had young kids, and she would prefer to have lived there with her son. However, she didn't want to be trouble to the son's family, and she purposely decided to move out of the home to live in an assisted living facility because, again, of the benefit for the family. So tip number 2 is acknowledging traditional filial piety can influence families to pursue intensive end-of-life treatment that may conflict with the patient's desire for comfort care. And knowing this and acknowledging this as a provider can actually help build respect and also potentially decrease the medical team's moral distress. Here's a picture, actually a classic painting from the Song Dynasty. You can see it's depicting classic filial piety with the son kneeling before the parents. So remember that you may hear the statement that our patients' families say, please do everything. Well, the traditional filial piety is the Chinese version of do everything, really out of respect for one's parents. So xiao, xiao in Mandarin is the fundamental virtue. It's actually a virtue in our Chinese culture that emphasizes respect, obedience, and caring for one's parents into old age. And this is deeply rooted in the Confucius philosophy. So then at the end of life, Chinese family may perceive continuing life support as actually fulfilling one's filial responsibilities. And this is actually praised by the social norms, okay? And then advanced care planning and foregoing aggressive treatment may be viewed as very unfilial. So then I suggest that we can actually reframe how we discuss advanced care planning as part of the filial duties of honoring one's wishes. And I would say this is a challenge to our elders, which is for them to actually model and initiate this conversation for their kids. Okay, so we're going to go to tip 3, and this is really talking about, so in contrast to the American culture where discussing advanced care planning with Chinese patients is very direct. What do you want? What do you not want? Let's not talk about what family wants. In the Chinese culture is this indirect way because we really don't want to offend the patient and the family. So framing advanced care planning as a way to reduce family disharmony, burden, suffering, and then it's actually a way of promoting filial piety. So many Chinese patients don't want to be a burden to their families, and they'll tell me that. And this is a great segue then to introduce advanced care planning and to start the conversation early. Now, you can also ask patients to discuss their perspectives, but not on their experience, but on someone else's end-of-life experience. So asking patients, for example, and by doing this, you can actually indirectly get a sense of how the patient is feeling about a certain scenario without point blank asking them. So for example, you can say, well, gosh, can you tell me a time when you knew someone, family or friend who's been ill or hospitalized, for example? Then you can also use hypothetical scenarios, asking the patient's opinions rather than directly asking them about their preferences. So what you can say, for example, is, let me share with you this hypothetical situation of a patient who has advanced cancer, and there's really no more treatments left, and they're now hospitalized, and they're very weak. So tell me, what do you think about this patient's situation and the decision that the family may have to make? And then also using providers' personal experience to start the like advanced care planning conversation. So oftentimes when I'm in a palliative care consult, I'll use myself as an example. I said, in addition to being a doctor, I'm also a patient at Kaiser Permanente. And so I've appointed who I want to be my healthcare decision maker. So it's my husband first, and then my parents, because they live in Daly City, very close to me. And so I want all three of them to be my decision maker. So I've done that, and I've turned it in to my primary care doctor. And so again, emphasizing the importance and also encouraging them to do the same. And then normalizing it, right? Then you're also normalizing it. Okay, the heart-to-heart cards. Yay! So Jeannie has raised them up there. So if you have not had a chance to play this or know about this, I highly recommend you talk to our volunteers here at CACC. I had a chance to play this when I was in Wuhan, China last year when I was teaching the LNEC. And you will all have an opportunity tomorrow afternoon at Stanford to also do this. So please register, putting a huge plug in. So I'm actually going to bring my parents and we're going to do this together. So this is a great tool to actually talk about their wishes. Okay, let's go to tip 4. So tip 4 is about using interpreters, okay, to discuss sensitive topics such as end of life, and then to accurately be able to describe palliative care and hospice care. So many Chinese patients lack English language proficiency, so making them more vulnerable to healthcare disparities. So really using the interpreter really diminishes those healthcare disparities, and it can actually increase patient satisfaction, improve their adherence and outcome, and reduce adverse effects. As we learned from Dr. Lu, there's many ethnicities in China, and many of our Chinese Americans speak many dialects. So if you have a Mandarin speaking provider, I saw out in the front, there's many Chinese speaking providers here at El Camino. If it was a Mandarin speaking provider, you cannot assume they can actually talk to patients who are Cantonese speaking. Okay, so it's easier for Cantonese speaking providers to talk more in Mandarin rather than the other way around. I'm not sure why. And then I think many of us already know this, right? We don't recommend using family members to be interpreters. And so please always offer professional interpretation as much as you can, especially when breaking bad news, talking about end of life care. So when I was a fellow at Harvard in doing my palliative care fellowship, I was in a consult, and the family member was the interpreter. And the oncologist essentially said to the patient that, there's no more options, really, there's no more options left. So then the family members interpreted that the oncologist said, we're going to wait for a little bit. We're going to wait for a little bit until things get better, and then we will see. So I would say as the care team, is important to not just say the word palliative care, because just like in the American word palliative care, no one really can know what that is, and there's still a lot of confusion. The same is in Chinese. 缓和疗护 is the Chinese. No one knows really what that means. So you're going to have to explain when you're using the interpreter, we're the palliative care team, and what we do is to help with symptom management, help with coping, resources, advanced care planning, and support, and then have the interpreter translate exactly those things, okay? So in getting ready for this talk, I said, well, gosh, let me just Google, right? We love Google. So I Googled palliative care, and you can see palliative care was translated as 安宁疗护. Yeah, 安宁疗护. I'm like, okay, that's interesting, because I had been learning from Sandy Stokes as 缓和疗护. I had to practice that for a long time. And then I decided to go Google hospice care. Oh, look at that. Interestingly, it translated exactly the same as palliative care, 安宁疗护. So you can imagine the confusion for both patients, families, and also the medical team as well. Okay, so we do have, thank you again to see the works of CACCC. They actually have a glossary of these important terminology on their website that you can download. Here in this paper that I co-authored and published, looking at key translations, key translation of terminologies for everyone to consider as a reference. And you know what? It's a great way to learn Chinese. So if you're wanting to learn Chinese, this is a great way. Okay, so let's go to tip 5. So tip 5 is really providing food at the end of life really represents filial responsibility, hope, and expression of affection. So food is the language of love in the Chinese culture. You know, when we meet people, we don't say, how are you? We said, have you eaten? Have you eaten? 吃饭了没有? Right? So has my grandmother over the year, have she ever said, I love you in Chinese to me? I cannot remember that at all, but she's made me dumplings. She's made me, wontons and chicken soup. That's her way of showing me how much she loved me. When my grandmother was dying, my father was, and she couldn't really eat anymore. My father, I still have this vividly in my mind, was feeding her watermelon, There's fear of suffering and death by starvation. And this, again, can prompt requests for artificial nutrition and hydration. And interestingly, I was learning this when I was in China last summer, that in China, as part of comfort care, you can, Dr. Lu can correct me, can actually provide IV hydration as part of comfort care. And so I had a patient in my clinic who had head and neck cancer. And he was actually, his job was a comedian, and he had head and neck cancer, and he was at his end of life. We're talking about hospice care with the daughter, because we couldn't talk to the patient. And the daughter said, Dr. Lu, can we have, can he get some IV hydration? And I had to explain, his body is shutting down. And when the body is shutting down, the hydration actually is no longer helpful to help him live better. If anything, is prolonging the suffering and the dying process. So tip 6, many Chinese American patients actually can be open to hospice when you discuss it in a very practical way. Trying to explain hospice as this philosophy, this holistic treatment is too vague. Chinese people, very practical. We want to know, what can you do for my loved one? So what can you say instead? You just can say, gosh, hospice has a nurse's aide that can help with bathing. And then there are home equipments like hospital beds and oxygen that can be delivered. And then, of course, you have to confirm and make sure the hospice will pay for it. Oftentimes, most will, but you should confirm first. They'll actually pay for some of the equipment and the medications that are covered. And then the nurses will actually come and see your loved ones, help with symptom management, help with wound care. When you explain it this way, they will be more open to receiving this type of care. Lastly, this is my last tip. So Chinese culture inherently respects physicians, so it's important for clinicians to build this trusting relationship and provide the safe space and be comfortable ourselves to actually make recommendations. So really leveraging that by proactively discussing advanced care planning and palliative care. So here are some social etiquettes you can consider. So knocking on the door, right, before entering the hospital room or the consult room, handing in business cards or documents. So we don't ever hand it in like this. We also use 2 hands, hand it in with the bow, showing respect. Addressing using titles on honorifics rather than first name. So Professor Wu, Teacher Lao, right? Or Dr. whoever, so using honorifics. And then balancing this indirect nonverbal communication techniques. Here's an example is, I read in Chinese, I read that Chinese American patients prefer to avoid taking morphine, even if they have severe pain. Gosh, does that apply to you? Okay, so if you want more, learn more, I'm so proud of this collaboration I did with Dr. Cynthia Pan, Chief of Geriatrics at Queens in New York. During the pandemic, we actually published this paper and then invited many of the collaborators. Sandy Stokes is one of them here with the top 10 tips palliative care clinicians should know about caring for Chinese Americans. This is a picture of my family during Chinese New Year. So that's my dad dressed up I forget, there's like a Chai Shenye, Risk, who gives out money, right? So my mom, and then her dog, which is really her granddaughter, you know, and then my youngest son, Liam, and then my husband. So this is the modern Chinese family. So in conclusion, Chinese patients is an integral part of the family structure and the influence of collectivism over individualism, and appreciating the culture, the traditional familial duties, and then incorporating this new approach, right, to filial duties in advanced care planning, medical decision-making, and also end-of-life care. And lastly, I hope you took away some tips that you can practice and use when you care for your patients with serious illness. So here are my references, and thank you so much. Thank you so much.
Thank you, Dr. Lowe, for another wonderful talk, for your service. This is what we're going to do. We have 4 panelists that you haven't met yet, so we're going to give them each about 5 minutes to introduce themselves, and then we'll have all the panelists come up here and sit and start answering. We have Dr. Gideon Sughrue, who's one of the co-directors of palliative care. I understand your colleague, Kat Barnett, is here also. Reverend Bill Leung, who's one of the associate chaplains here at El Camino. We have Peining Chang, who's a social worker with the Alzheimer's Association of Northern California and Northern Nevada. And then Sandy Chen Stokes, a nurse who's our CACCC founder and interim executive director. So I'm going to turn things over to Dr. Sughrue first.
So good morning. Thank you for having me here. It's a privilege to meet the people in this room who are so passionate about the care that they provide, and also members of the community who are really advocating for patients to receive the type of care that they want with their families. So thank you so much for this invitation. I wanted to talk a little bit about what is palliative care here at El Camino, who, what, why, and when, or at least some of those topics. I'm Dr. Gideon Sughrue. I provide oversight as a clinical medical director, and Dr. Kat Barnett does a lot of the some administrative and education portions here in the hospital at El Camino Health, and also provides some palliative care help as well. Okay, so this is me, Dr. Gideon Sughrue. I first went to school and studied what we would call allopathic medicine. Did a residency and did a lot of training in hospice and palliative medicine. And then actually got very interested in terms of what were other options for pain and symptom management. And some of my colleagues where I was working when I used to be at Kaiser with Esther, I actually left and went and studied acupuncture and Chinese medicine at Five Branches University, and completed my doctorate in acupuncture and Oriental medicine, which is a technical term. It's a 2-year postgraduate degree. I'd also done an apprenticeship with a Chinese medicine professor and acupuncturist from Beijing Chinese Medicine University Hospital as well. So what is palliative care? It's a specialized patient-centric team-based care focused on pain and symptom management. We often have nurse practitioners, physicians, social workers, and chaplains. So really the goal is to help the patients achieve their best quality of life possible. And why is this important? It's because, as I think our previous speakers have alluded to, there's increasing numbers of patients and just people in general who have complex illness. And so we really want to help them live the best quality of life possible on their terms and what it's important to them and their families. So really, what makes the difference? When is a time to think about getting palliative care involved? Oftentimes people really think palliative care is consistent with hospice care, and they don't really get us involved until there's like maybe a week or a couple days left to get involved. But actually, it's really good to get palliative care involved when someone's diagnosed with what could be a potentially life-limiting illness, because then we can really start the discussion about what is going to be important to that patient and their family in terms of their care going forward. And as they're receiving their medical care, if they have pain or other symptoms, how can we really help them address that and receive the care that they need from maybe different medical specialists in the medical system? It's going to really help them achieve their best quality of life. So things that we often think about, different patient populations that we would like to see who may be appropriate for palliative care, could be patients with a new cancer diagnosis, patients with advancing lung disease, heart failure, kidney disease, and progressive memory loss or dementia, to name a few. And what is palliative care? Why is palliative care important? Because for about 66% of patients, it's been shown in a couple different studies to really help improve to reduce the symptoms and improve their quality of life as they're going through the process of their life, which could be potentially towards death. And about 93% of patients who receive palliative care are often going to recommend it to their compatriots. So another big discussion is really thinking about what's important at people if they may be going towards their last days, weeks, months of life. Do they wish to be in the hospital to focus on having every single moment available? Or do they prefer to be at home, engaging with their loved ones, participating in life on their own terms? And so for some patients who don't have discussions, this is really what we would call their last rites, where they're going through the process of dying rather than having their family and friends present on their own terms. Sometimes they have CPR and the medical team present, and that's really what we'd almost call their last rites. So looking at patients who live in the state of California, this was a survey looking in 2014 about, do patients want to talk about the end of life? And, sort of where would it happen? Patients, I know this may not be always contextually consistent with what we might find in the subculture that Esther and Dr. Lu have alluded to, but this just gives us some context. In the state of California, about 47% of patients said they would want to talk to their doctor about end of life. And about 32% said probably, 16% maybe. So that's a large portion of population want to have a conversation with their clinician. So, and then where do patients want to maybe spend the last days of their life? Approximately 70% said they may actually want to spend that at home with their families. So this is consistent about having an open discussion on their terms with their family or whoever else is important to them. Where does it actually often happen? About 32% is at home, maybe 42% is in the hospital, maybe 18% is in nursing homes or other assisted living facilities. So it's really having a discussion. Is a majority of people say that they would want to have what they call a natural death, and only 7% say they would really want to be hooked up to a ventilator. And so if people are met on their own terms and we really connect with them from where they're coming from, then we're able to facilitate that discussion and really, if they want to participate or do they want their family to participate, really trying to meet them on their own terms. This is our El Camino palliative care team. There's myself and Dr. Barnett, who's also a physician. We have some nurse practitioners. We have 3 full-time nurse practitioners and about 3 to 4 per diems. We have 2 full-time social workers and 1 chaplain. We have our nurse case manager, Gretchen, here. This is Dr. Barnett, who's also an ER physician and also has a pet therapy dog that she brings into the hospital by the name of MJ. And also we're starting to offer now integrative medicine because I'm an acupuncturist as well as licensed. And so now we offer that as part of our pain and symptom management to our patients who are here in El Camino Hospital. And we are also, Dr. Barnett teaches a course she just completed back in March, and look for ones that'll be upcoming, really teaching physicians, and it'll also be opened up to other staff about really having difficult conversations, and this is powered by Vital Talks. I really thank you for your attention. I apologize if that was a little bit rushed, but I really wanted to give a little bit of an overview about palliative care as Esther has, and Dr. Lu, and then also what we do here at El Camino. Thank you so much.
Thank you, Dr. Sughrue. Next, we have Reverend Bill Leung.
Good morning. I'm Chaplain Bill Leung. I've been with El Camino for the last 8 years, 6 years as employee, and I work for the spiritual care department. And a lot of the patients, when they see me, they have a misconception of what a chaplain does in the hospital. So oftentimes I have to explain to them I'm there just to provide them with spiritual and emotional support, not so much about religion. But of course, if they want to talk about religion, we can do that too. And we also have spiritual care department has a long list of support from other religions. So if in case the patient wants to talk to someone with their particular religion, we can contact them to come in to provide them the support. So a lot of people think that also a chaplain, oh, you must be a Christian, you must be trying to convert me. And sometimes I have to explain it to them, that's not true. Chaplain can be from different religion, and we're not there to impose what we believe onto them. So this is my daily work, and we're there just to provide them with spiritual and emotional support, and we do not, we go to them with no assumptions, because patient can be from different background, as you learned today, different cultural background. And if they have been, even if it's from China, if they have been here in the US for a long time, they become a little more Americanized. So it's a wide spectrum of expectation. And we don't have, and I told them, I don't have an agenda. I'm just here for you, whatever you need. What can I do for you? That's my question for them. So we don't impose, we don't dictate what we should do, and it's all up to the patient and the family. So just being here, you know, we do our best to provide them with the support that they need, and so that's my introduction. And I was born and raised in Hong Kong, so I came here many years ago. So I learned my Mandarin from my church. So I speak both Mandarin and Cantonese, and really help in doing my line of work. Thank you.
Thank you, Chaplain Bill. Peining Chang.
Okay, thank you for this opportunity to have me here. Sandy insists I have to share. So I learned a lot this morning from Louis and Lois. I've been with the Alzheimer's Association for 17 years. Now I'm the Senior Community Engagement Manager for Diversity, Equity, and Inclusion team, overseeing API outreach and services. So at first, I want to just share some basic information of the updates of the yearly Alzheimer's disease facts and figure. There's no sound here. Okay, so let's just take a look at the numbers. Nearly 7 million Americans are living with Alzheimer's. Over 11 million are unpaid caregiver. They are stressed when coordinating care. 3 in 5 caregivers say less stress or peace of mind if they can have a care navigator. We need your help, and also families need our help. Because as you all know, for families impacted by Alzheimer's and dementia, the chance to talk about end-of-life care is limited, not like any other disease. Especially for Chinese culture, people reach out to a doctor for Alzheimer's or dementia diagnosis way later. Especially for Chinese, they always wait until there are behavior issues, so they don't know how to handle, they reach out, but it's usually toward middle stage. So that's why it's very important for all of us to keep talking about the importance of early detection, because that's a precious only a few years at the early stage of the disease that the person with dementia can share what they wish. And many families that I help with eventually end up with a lot of conflicts because all the siblings have all different ideas of how to care for mom. I even sitting with the family meetings that 3 siblings, they all want to do the best for the mom, but one is like executive in a high-tech company. One is wheelchair bound, the sister, and the third have other issues. They all have their opinions how to care for mom, but they all have their limit. And that conflict lasts for many years until one day that somebody told them, you have to go talk with someone at Alzheimer's Association. And after that meetings, the eldest brother said, this meeting helped us solve many years of siblings conflicts because they didn't know why the siblings are thinking this way, but they all want to do their best for their families. For Alzheimer's, it impacts not only the primary caregiver, it's the whole family, physically, emotionally, social, financially. And a lot of times it falls on the daughters or the daughter-in-laws. So you can see many of them are really stressed, but still relatives still blaming them, not doing the best, because most people don't understand the progression of the disease. Every half year, every couple months, they visit their loved one. They will say, how come her condition is getting worse and worse? It's because your daughter-in-law didn't care better, so my sister didn't get well. So the aunt will blame the caregiver, the daughter-in-law, and she's so stressed, I haven't done my best. So lack of understanding of Alzheimer's disease, the progression of the disease give a very serious toll on the primary caregiver. Even the primary caregiver wants to have a family meeting. Sometimes the other siblings don't want to join because they think dad is still looking good. Every time I visit him, he's still happy. He can carry some conversation. But if you don't live with them 24 hours, you don't know how stressful the primary caregiver feels. And for APA communities, like Louis and Lois mentioned, the decision is not solely on primary caregiver. It's always the family decision. And usually it's the eldest one making the decision. So we encourage families like understand the late stage, what's the progression, and the support services like the hospice should come in at this time. End of life care is a team, and usually family will need special help to managing the end of life care. So we educate family members, 10 tips to care for someone with late stage. And we talk about the needs because people always feel like those doctors said, it's giving up my loved one if you bring a hospice care. So that's the family feel this way. It's the culture, right? You want the best for your loved one. You want them to be feeling better and better. And also there is a myth that hospice will leave the person that care for drug and unable to function, will actually provide the care the person needs to managing the pain. I hear family members share that when they receive the hospice care, maybe the hospice program didn't explain well enough about the dying process. So even though they accept the hospice care, after her father passed away, she shared with me, it's really difficult to see my father not being given any food, like doctor just mentioned. It's really difficult, and I still feel bad that I didn't give any food to my father. So I think the education of active dying and what's the best for someone with the disease, well, not the best for family member to feel, right? It's very important for healthcare professional to mention that. And for dementia families, we need to start a conversation early, and it's very difficult for Chinese families because first, if they don't understand this disease progression, they always wait until there's no time for family to hear what the person with dementia wish. And also, there are some information that may be helpful near the end of life, how to honoring their wish, how to understand treatment option. And very important is resolving family conflicts. Like, even though sometimes you may be the one who knows the best about end of life, but you're the youngest in the family, you cannot make the decision. So many families experience that. So we always remind the caregiver, you've done your best because you know everything, you've done your best, but sometimes things is out of your control because of the culture of filial piety. You need to respect your family hierarchy. So caregiver, just remember you've done your best. And even after a loved one pass away, many family caregiver will share, I should have done this. I should have do this more. Everybody has so much guilt, but they actually already done their best at every moment they can do because they are going through so many decisions for such a long time for dementia journey. Okay, so we can skip the video. It's the caregiver. She also share, she fight with the doctor. She refused the hospice, but eventually when she accept, it's really helpful for her family. So we share with caregivers that end of life is a mix of feelings, especially for caregiver with dementia. Many of them, they feel a little relief, and they may also feel guilt. How come I feel relief now? But it's natural because many people go through dementia journey sometimes as long as 20 years. Every day it's a long goodbye of one of their loved ones' abilities. So try to call on others. And Alzheimer's Association is here to help making decisions, providing support. A lot of information is online, and we have resources outside. And I think one thing I want to mention is many Chinese family here, because first generation is still following the traditional culture, but the second generation growing up here is accepting American culture. So there are a lot of conflicts for making some decisions. Like the last story, like one family I work with, the mom will trying to save a lot of money to give to the daughter. She said, that's my in Taiwanese term, I'm from Taiwan, it's 卡位金, 家位钱, like you save the money for your children, while the children will say you should spend the money to care for yourself or hire care to provide care for dad, so you don't need to be so stressful. So, and the two cultures, they're trying to balance and trying to provide the best care for each other while provide the best for your next generation. So it's a very difficult balance and the difficult art, but we do our best and encourage our family to try the balance and just tell themselves they've done their best because it's a long journey. Thank you so much.
Thank you, Peining. I'd like to next introduce Sandy Stokes.
So bear with my Chinese English, okay? So I want to thank everybody, Jen, El Camino Hospital, Chinese Initiative, Health Initiative, and everybody here, our panelists, Dr. Lu, Dr. Lee, and thank you to make this possible. I really appreciate. I'm a nurse. They want me to talk about from nurse point of view about end of life. So I want to say I'm a nurse, very proud nurse, since I was 19. And I'm 70 now. So go figure how many years of a nurse I am. I love to be a nurse. So people in my family, including, always ask me, why doing end of life care as a volunteer? After all, you don't see enough deaths and dying. Okay, so that's the question, always particular first year or two. My dad, I talk of this story many times. When he was 83, he was admitted to a local hospital in Taiwan for a GI infection, and he never get out. The thing is, he was stay in the ICU for over a year. Yeah, I saw doctors. Wow, yes, for over a year. Not a year, 1 month, many months after. And then at that time, it was back in 1999. Taiwan wasn't legalized with the DNR. We don't have AHCD. Okay, that was 1999. Year 2000, they start have this legalized form, and the patient or family can request. At that time, I asked the doctor about any possibility of a DNR. And then by the time probably I came back next time, I was labeled as the daughter came from United States. Very bad daughter. And Chinese called 不孝女. How to say that in English? 不孝女. Not value daughter. Yeah. So that's me. So on the way back, fly back after my funeral, I was thinking, I said, I've been doing this in California since couple years ago, promoting end of life, particularly do the advanced healthcare directive form, had to translate and everything. I made my decision. I said, I want to refocus all my volunteer work into end of life care for Chinese American. Why? Because we are so lucky. We're in the United States, right? We have this documentation, and patient and health provider is so fortunate we'll be able to have discussion before it's too late. But at that time, Chinese American even not heard about. And you think they might sign the paper. They did sign. They don't know what they signed, right? So that's a sad part. So that's our decision to do that. But why coalition as a Chinese American coalition for compassionate care? It's because I know I'm owning a nurse. I'm owning by myself. Got to form a coalition to work with mainstream health providers to work together, because where the Chinese patient need end-of-life care in the facility, in hospice setting, right? And then also with our grassroots organization, like Alzheimer's Association. And so that's how we form a coalition. Now, this is the historical photo we did in 2014 when we first had a heart-to-heart car. It's in this room, exactly this room. We can say quite a few people still here today in this room. And we also have our volunteer start from 2005. We established CACCC. Jeannie Wan is one of them. And then all other, my colleagues and volunteers are here. So the best way to thank our volunteers, I like to show people a PowerPoint. If you already saw that, please do it again. You might find somebody you know of again this time. And then I have to say that I have a lot of people to thank for, but I want to say that as a volunteer here, we saw quite a few people wear the green t-shirt, right? All our volunteers. And they have their own professional. And then they came here. It can be health provider, probably not, but they came here for only one reason. And I always tell my loved one and my close friends is, Why I doing end of life? Because I'm not normal. Because Chinese American, nobody talk about this. They run as fast as they can. You are not normal. So I say, yes, I'm not normal. But then I realize after all those years, I realized I'm not normal. Because I saw all my volunteers, they come here, we are normal people. We do some so-called normal services to people who need help, either patient or their family. But we lost, my time is 0. But then we do this all together. It's just like every one of us is a drop of water from the heaven. We drop to the ocean. It will never dry. And you're all our volunteers. Even you don't label yourself as a CACC volunteers. You hear whatever Dr. Lu and Dr. Lo talk, you share with others. You are our volunteer to serve the patient facing serious illness. So I thank you. If we have a time later on, I really want to show you a photo. They will know why I so much appreciate all of you. Okay, so thank you.
Thank you, Sandy, and thank you to all our panelists. So we have a lot of questions and a few minutes left. So I'm going to try to address a couple of the important ones. And maybe this question will be for Dr. Lu and for somebody from El Camino and maybe for Dr. Lo from Kaiser. The question has to do with access to palliative care. Who or how is it decided that it's time for palliative care? Along those lines, how do you get referrals? Are they coming from other doctors or from other people in your system, or is there some other way of identifying patients? So, Dr. Lu, maybe you could start with that, or?
刚才问题是我的病人从哪儿来？因为我在国内做安宁疗护，有一些知名度，所以说我的病人都是单独挂我的号来的。
Because I have something back in China, so people always come just to make appointment with me directly.
我的病人大概有2/3的病人是没有机会住进安宁疗护病房的，我们根本就不缺病人。我认为要不先来。
2/3 of my patient, they don't even have a chance to be admitted into the hospice ward.
其实，在我们看来，就我个人观点来说，别人转介的病人并不是最优质的病人，往往是急诊科啊各种科室，他们治不好又没地方去，而且医保又到期了没地方去，推荐过来的这种病人往往没有很好的死亡准备，并不是特别优质的病人。
Yeah, to me, for whoever that's referred to my clinic, I think they are not the best candidate for me. It's actually those patients that was admitted to ED and really need help. Those are the patients that we want to help.
Okay, thank you. Dr. Sughrue, do you want to go next?
Sure. Can you hear me? Great. So in the hospital, currently El Camino has multiple different provider groups. We have PAMP, we have Team Health, and we have some independent providers. So that's what makes El Camino such a rich experience. Currently in the hospital, we can receive consult requests from any of the physicians, or the nurses can request the physicians to put in a referral as well. And families can also just request directly a palliative care referral, either to the nurses, the social workers, or the physicians. And they will put an order into the computer, and it will say El Camino Palliative Care Physician and Team. And then we're contacted, and they can also reach out to us on our palliative care line as well. So, which I believe is 650-988-7624. Sounds like an advertisement. So that's the way they reach out to us. And then from there, we're able to initiate contact with the family and the attending physician and any subspecialists to really get the background information about what has really brought this patient through the whole process. As my colleague here says, when they come into the hospital, receiving the consult earlier in the clinical course really provides the best support to the family and to the patient and to the clinical staff here in the hospital rather than in the last, days or hours when the patient is dying, which we've also received consults then as well. But then we really are not able to help have communication and support to the family and the patient.
Great, thank you.
Yeah, so I'm a practicing palliative care physician at Kaiser Permanente in Santa Clara down the street. I do mostly outpatient palliative care. At Kaiser at Santa Clara, we have palliative care across the continuum. So in the clinic, in the nursing home, in the hospital. And I'm also really proud that my retired supervisor, Karen Chu from Home Health, we initiated a home health palliative care program. So we'll see patients in the home setting as well. Patients, families can directly request a palliative care consult. I have never seen the doctor refuse when it comes from the patient. Okay, so you can do that directly. Patients, doctors can also put in the request. Who qualifies? Anyone with a serious illness. How do we define a serious illness? Anyone who has a medical condition with a high chance of mortality, distressful symptoms, and distressing family members. You can get a palliative care consultation, not just at the end of life. Okay, I want to make that very clear. Not at the end of life. So at Kaiser Santa Clara, we have a collaboration with our oncologists. Anyone with a newly diagnosed stage 4 GI cancer will get an initial outpatient palliative care consultation. So early in the disease process, like our social worker mentioned here, that dementia patients do not wait until it's advanced, right? Because then the patient can't really speak anymore for their own wishes.
Thank you. Okay, I think we have time for one major question, and maybe Bill and Dr. Lu, you can help to address this regarding spiritual care. I just want to warn all the panelists that after this question, you will each have a 1-minute speed comment opportunity. So be thinking about that, okay? So this question revolves around how spiritual needs are addressed, and do hospitals in China have chaplains? And in general, how do you address spiritual beliefs, or what model do you use for spiritual, social, emotional support?
I usually do a spiritual assessment, not in a way of questions after questions. It's just through my talking to them and trying to assess their spirituality. For example, I ask them, how are you coping? Your illness, and how are you in distress spiritually? Or what are you looking for? I bring it out different time as I was just talking. So I don't want the patient to feel that I'm questioning them. So in that way, I can have a pretty good idea what I needed to do. And everyone is different, right? Everyone is spiritual. So I cannot have the same way for one patient and all the patients. All kind of like customized and tailor-made. It all depends on their needs.
Dr. Lu?
灵性在中国，它误认为就是直接是宗教，所以说灵性的词在中国没有特别多的直接讨论的空间。
Yeah, spiritual care in China was mistaken as your belief. So we really don't have much opportunity to talk about spiritual needs.
但是我们知道灵性它并不等于宗教，灵性是大于宗教的。
To us, listening to the patient is more important than talking about patient's belief.
就像中国有句话，道可道，非常道。其实灵性也是灵可灵，非常灵。一旦给定义，就不是灵性了。
So whoever under Chinese understand why I kind of because Dr. Lu is very good with Chinese literature, so he's using some old way of Chinese saying. So basically, he is saying that even though we don't deal with spiritual care, but we respect their culture, respect their belief, and we just work with them. That's the most important part.
Yeah, thank you. Great. All right, I think we're going to start I'm going to start at this end, Dr. Sughrue. Everybody has 1 minute for any kind of closing comments or thoughts. So go.
This feels like speed dating. So I would really want to say that here at El Camino, we really welcome everyone along the course of their life. And please remember, as a patient, to ask your doctor for a palliative care consult if you're going through a serious medical illness that may be life-threatening. It can be curable or may not be curable. It could be for an infection. It could be for a heart attack. It could be for a stroke. It could be for cancer. Asking for palliative care doesn't mean you're giving up. It means that you're asking for the best support to live your best quality of life possible.
Very good. Sandy?
Okay, to finish what I was trying to finish. What I tried to
1 minute, Sandy.
I understand that I'm very happy to be here back again for the third or fourth time. And I can see that we are really working together. We all realize end-of-life care is so big and so important and affect everybody, right? So we cannot only rely on hospital or one hospice. We need a community involvement. Place like a CACCC, we have so many excellent trained by everybody here, and we put together, work together. So that's really start working to make more services towards not just Chinese American, any cultural diverse who need help. We identify the leader of that group and work together. I think it can be done. So thank you, everybody.
在中国，我们面对生死，经常说人的一生，生不带来，死不带走。
In China, in China, we always say that we born with empty-handed and we left with empty-handed too.
但是我们做了安宁疗护，发现爱可以温暖30两生。
Yeah, but we realize doing the hospice care, we know with love we can warm everybody in so many ways.
安宁疗护通常说起来是始于生命教育，对生死教育，但是恰恰是这些安宁疗护从业者是第一代被患者教育的。
Yeah, so even though hospices are trying to care for end-of-life patients, but we realize it's the provider that benefits the most. They learn the life lesson from all the patients they serve.
我们越来越发现，作为安宁疗护从业者，我们的责任是生为患者疗伤，事为患者代言。
So learning from my hospice experience, we know that when the patient is alive, we are trying to heal them, to help them toward their health. But when they passed, it's our responsibility to be their advocate.
Thank you, Esther.
All right, 1 minute, I'm starting the clock. So 2 things. So palliative care is about living well. So if you're going to walk away, someone asks you, what is palliative care? You went to a talk. It's about living well. Okay, how to help the patients and their family to live well amidst an illness that they have. Second, start the conversation early. Start it with yourselves. So I'm going to ask you, what matters most to you and your family? And what are you most worried about right now? And then share that with your loved ones so that they know what your wishes are.
From a spiritual care point of view, our goal is to help the patient to be at peace with themselves. Definitely talking is easy, but that's the goal. And also the family, they're at peace with themselves, even though they cannot change the outcome of things, but at least they come to accept it, they come to at peace, but that's spiritual care. So.
Okay, for my part, I will share in the most recent event with San Jose Japantown community. I have received a gift. There's a note saying, "Love is the only memory one never loses." So I will encourage all the healthcare professionals to tell and encourage your family to understand Alzheimer's disease and dementia better. Plan early, start a conversation early, and encourage the family to ask for help and ask them to accept help. This disease cannot be cared by just one person. Ask them, encourage them to accept help. That's the biggest love you can give to your family. And also encourage them to tell them, no, you've done your best every day. That's all. Thank you.
So my final comments about this are that I'm struck by how much, as healthcare practitioners in this field, we have in common in assisting people with living their best life and living a good quality of life. I'm sure that those of us who do palliative care are often asked by our families and friends, how do you do this work? And for us, it's really a privilege to be able to be with people when they're trying to figure out what to do when they have limited time and what's most meaningful. So thank you to everybody who's contributed this morning. I want to invite Dr. Lombard to come up for some closing remarks.
Speaking as an ethics committee member, I applaud all those people who are interested in moving this forward. I've started my discussion with my end of life, and my son said, I don't think you should get cremated. I think you should get composted. So that's he lives in Santa Cruz. So that's the way I'm gonna go. Thanks, everyone, and have a great day.
Thank you. And so I want to remind you of our sponsors. They're up on the slides. Once again, our platinum, silver, bronze, and copper sponsors, and then collaborating partners.